tips on urological treatment procedures during this unusual situation. So before I will hand over to our hosts, I will just shortly introduce myself. My name is Christian Behrens, being the Global Product Manager at Dornier MedTech. And I will also take care about some technical things up front. As you can see here, point number one, for those of you who want to see the speakers in our panel, here on the top right side of this slide, you can see how to change the position also of the speakers of the video that you can see. Point number two is highlighting all the questions and answers that you might have in the audience during the webinar. You might raise those questions in this questions and answers box. The questions will only seen by us, by the organization team. So none of the rest of the audience will see that question. We try to answer all your questions, but we have a huge number already joining that meeting, that webinar. So we will see how many questions and answers we can give in the end of the discussion of our panel. And another side note is side note number three. The chat function itself will be disabled. So if you have any questions that should be answered in the end, please do this via the questions and answers box. So now it would be a pleasure. It's a pleasure to hand over to Samir. Samir, my colleague, it's your time to start.
Thank you, Christian. A warm welcome to all the participants. I'm Dr. Samir Parmar, Global Clinical Application Manager at Dornier MedTech West in Germany. Welcome to the first series of Dornier's webinar, COVID-19 Spotlight on Urology. Since the outbreak of COVID-19 in December, the virus has spread globally, WHO declaring a global pandemic in March 2020. Many countries are taking preventive actions like acting on the social distancing, other measures, and healthcare systems are heavily impacted. As a physician and the healthcare provider serves to be the frontliner in responding to this crisis. Physicians of all specialties are impacted, and in particular with spotlight on urology, today we seek to understand the situation faced by the urologists and their patients, including those suffering from urolithiasis, BPH, cancer, and other elements. With surging number of COVID-19 patients and casualty exceeding more than 183,000, we would like to understand how COVID-19 has impacted the practice of urology. We are thankful to our distinguished panelists today from the countries that have seen the severe COVID-19 outbreak. Our first panelist today is Professor Kemal Sarika from Istanbul, Turkey. Professor Kemal Sarika is chairman of EUA section of Urolithiasis and also the co-chairman for International Alliance of Urolithiasis. Professor Kemal is the member of editorial of several international urology journals. He has over 204 international publications and over 13 chapters in various books of urology. Our second panelist for today is Professor Domenico Prezioso from Napoli, Italy. Professor Prezioso is a chair of urology at University of Federico, Napoli, Italy. He is General Secretary to Italian Urology Association for Urolithiasis, an active member of ULIS Advisory Board. Professor Prezioso is author of over 100 papers in the peer-reviewed urological journal. Our third panelist is Professor Zheng Hua from Guangzhou, China. Professor Zheng is a professor of urology at the first affiliated hospital at Guangzhou Medical University, China. He and his colleagues created a unique mini-PCNL technique, namely the Chinese mini-PCNL. More than 30,000 Chinese mini-PCNL are successfully performed by Professor Zheng and his team. Our final panelist is Professor Ramon Cancino from Spain. He is the head of the stone and the endourology at University Hospital La Paz, Madrid, Spain. Dr. Cancino has extensive surgical experience in endourology and open surgery, especially for URS, RIRS, PCNL in prone. He is a member of RIRS Working Committee for International Alliance of Urolithiasis. Professor Ramon has numerous courses and several master's classes of endourology, and he has over 24 publications under his name. Without any further delay, I'd like to invite Professor Kemal Sarika to moderate our panel discussion with the first question. How has COVID-19 affected the practice of urology in your institution and in your country? Professor Sarika.
First of all, a warm welcome to all participants to the webinar. We have three different very valuable experts in stone management, and also they are coming from important countries which were affected from the COVID pandemic to a certain extent. Before giving my experiences in this area, I want to begin with Professor Zengua, because, the pandemic began first in China in December last year, and then European countries and the whole world were affected. For that reason, Professor Zengua, can you tell us your experiences with this question? How did your practice in urology, in your department, and also in your country change with this pandemic? Please.
Okay. Everybody, in China, local time is 8 p.m. I must also good evening. Actually, in Chinese government decided to shut down the city of Wuhan on July 23. The people who have high body temperature are not recommended to leave Wuhan. The second day, by city Guangzhou also divided shutdown. It is Chinese New Year that day. Usually, we have 7 days of national holiday. So everybody was encouraged to stay at home during the Spring Festival. All the cities in China image the inflow and the outflow of people during the Spring Festival in the first 2 weeks. This is very important. Basically, in the whole China, all infected case was limited and then controlled in Hubei province and the city of Wuhan. More than 40,000 doctors and nurses are all over China went to the Wuhan at the beginning of the pandemic. Now, all of them are already come back to the positive at home after about 50 days hard work in Wuhan. So far, in my city, is only 502 confirmed infected cases, and most of them are already fully cured. I would say early detection, early reporting, early diagnosis, early isolation, and early treatment is the most effective methods. Therefore, the COVID-19 didn't infect practice of urology in my institute and the country. We had a long spring festival for about 3 weeks at home, and then nobody will come back gradually. All the urologists in my department are obligated to learn how to practice in case of face COVID-19 patients, such as how to wear the protective suits, how to report the suspected case, and how to manage the confirmed infectors. Our new and follow-up patients are suggested to use online surveys and telephone medical advice. Most of urologic consultants was use on app for free consultations. A temporary shuttle clinic was built in February in our hospital. Suspected infector needed to be distinguished from the other visitor in the temporary shuttle clinic. A questionnaire needs to be completed to clarify their epidemic history within the last 2 weeks. If a patient has a positive epidemic history, fever, respiratory system, he and she will be assigned to be designed related hospital for isolation and treatment. Yet, temporary shuttle clinic, urologists how to wear examination gloves and isolation gun, surgical mask, and eye protection, and disposable head and share cover in single room for face-to-face consultation. Negative complete blood count, chest CT scan, and throat swab DNA test was needed before inward admission or day surgery. Actually, the workload in the outpatient clinic was infected initially, about 60 and 80% in March, but now it come back as normal in April. Now one of my urologist colleague working for the COVID-19, but we have sent our doctors and some laws to Hubei province. One of my outpatient clinic, which just located next to the fever clinic and was closed in March, but now it is already open since April for emergency cases because our system is a bit different compared to the West. Our operation room is always ready for emergency cases, but they didn't have the test excluded COVID-19 first. Generally speaking, the practice of urology in China is really coming back to the normal. This is my opinion.
Thank you so much, Professor Zheng. As far as I understood, the hospital did not use your department for COVID patients.
No. Well, my department was used for COVID patient department.
Excellent. Thank you so much. Thanks a lot for this really very important information coming from the first country affected by this pandemic. And let's go to Italy. Professor Prezioso, your country was also really seriously affected by the pandemic. And what will be your comments to this question? What has changed in your country, in your department?
Oh, dear Kemal, dear friends, well, as you can imagine, changed a lot. Generally, there was a great decrease of any kind of urological activity. But we should say that in Italy, we had two different scenarios. In the north, especially in the first weeks, you remember there was the tsunami phase where we saw hundreds of people referring to first aid with a severe respiratory distress syndrome, and everything was dedicated, everything was transformed. Even, I would say, 99% of urological department for the COVID patients, because we were not ready. We were not ready, and in some place, especially in the north, grossly all the north, we had a great, as you know, focus of infection. In the center, in the south, well, everything was stopped, like all over Italy on quite 45 years ago. And we completely stopped any outpatient workload, consultation, only distance consultation. The telemedicine that has been promptly activated, like in our institution, the teaching or anything else from with computers. And we had to stop any kind of surgery. Only it was possible some urological, oncology patients, but looking at priority of symptomatology, trying to delay as far as possible also this patient. Especially in the first phase, we had no more available beds in intensive care. So the risk intervention or the advanced especially in the center and south of Italy, COVID dedicated hospital for the COVID patient, but also some big one where there could be possible specialty surgery in this infected patient.
Dr. Prezioso, thank you so much. Did you have lockdown measures in your city?
Lot of
Lockdown measures, I mean, stay at home.
oh yeah.
But
I think
still valid
next
now?
week, in 1 week, there will be a little, opening, and this could be a problem. This could be a problem because this means the risk of to go up with, cases, and without considering that infectivologists talk of a new wave, and also in Italy we are strictly connected with all Europe. So there will be also the big wave.
I see. Well, one more question. Were your team members, urologists, involved in the treatment of COVID patients in the hospital?
In my university, takes not only for urgency, but and we had to treat some of them, but in a specific dedicated area.
Right.
We had only to work for emergency, for people emergency, stone emergency, but this is where we had, and on oncology, of course, but also in this case, we have a lot of decrease because people scared.
Thank
the hospital also.
All right. Thank you so much. Thanks a lot. And now coming to Spain. Professor Cancino, you're my friend. What was the situation in Spain? Tell us something.
Well, thanks. First of all, I would like to thank you very much this kind of invitation. I think it's not because I'm an expert in COVID situation, but yes, because we are suffering in Spain a lot of problems with COVID. We are still suffering. I think we are starting to see the light at the end of the tunnel, but we still have a lot of people. We actually have more than 200,000 people infected and 33,000 people dead about the COVID. And especially in my institution, I can have a slide. I think maybe we have one slide that I have prepared. Samir? Can I have a slide, Samir, or what? The problem was that at the beginning we need to decrease our urological activity dramatically, because we had a lot of people in the emergency room waiting for beds, waiting for be hospitalized. So we had to decrease quickly our activity, and that was we need to do until the situation that we completely stopped. We didn't had any surgery from more than 1 month ago, and actually we continued without any kind of surgery. We have more than 1,000 people hospitalized in my hospital from COVID. We had more than 160, I think almost 170 intensive care beds occupied by COVID patients. And the operation rooms were converted in intensive care units. We had also 3 beds per operation room. And also we had prepared in the hospital 2 OR for emergency surgeries from COVID and 2 emergency rooms from no COVID. those were also for traumatologists, general surgeon, neurosurgery, urology, whatever. And that's all. That's what we had to do in that situation. And also, we had 6 of our partners, of our urologist department, fully integrated in emergency room. They were working together with emergency department in order to help whatever they needed and to do whatever were necessary to help them. And that's it. I would like to share my slides, but well, maybe later could be possible.
Okay. Thank you so much, Professor Prezio. So thanks a lot for the comments to the first question. If I tell something about my country, Turkey, the first case has been announced at March 11. And in the beginning, we thought that will be not that severe as in the other countries, like China, Italy, or Spain. But later on, we noticed that we will have also a pandemic in Turkey, and it affected also our departmental and hospital system. Outpatient clinic service decreased to around 60-70%, and also elective surgeries in the hospital were not allowed for a while. And the hospital administration told us that please only make the emergency surgeries, and for the elective ones, please postpone them. We had lockdown measures, and lockdown measures also did affect the patient's attitude to refer to the hospitals, and also it affected the number of cases referring to our hospital. So also in the department, the number of cases decreased, and our department was not used, but 2 blocks of the hospital were spared for the COVID cases, and the hospital administration began to deal with these cases. That means our outpatient clinic activities, departmental activities were severely decreased after the pandemic. And in order to limit the infection problem and the patients and the visitors, hospitals begin to postpone the elective cases in all departments, including us. My team was not involved with the pandemic, but I know in the government hospitals in Turkey, in Istanbul at least, all the urologists in these hospital departments stopped their urologic activities, and they were all dealing with COVID cases, including their departments. Their departments also began to accept COVID cases. That means, as my friends told me, blocked, stopped, these were the phrases that we can use, and later on we adapted, but it took and changed some, let's say, practices in our routine, particularly for stone. So let's come to the second question, Samir. Let's ask the second question to our panelists, the second one. So, pandemic also did change our attitude for the surgery for stones, their treatment. Here is the question. What impact has COVID-19 had in terms of patient selection and treatment options for stone patients, referring to your either emergency department or directly to your department? Professor Zeng, please tell us something. How did your attitude in the management and patient selection change?
Okay. Actually, for renal stone patients in our department, the first months after pandemic outbreak, shock video strips become the more widely used for stone less than 2 centimeters patients. That helps avoid close contact between patients and the doctors. Also, to reduce the use general anesthesia and ventilators. We often super midi PCNL with palatable block anesthesia for some selective cases. It also helps to avoid the use of ventilators. Patient can go home 5 hours after admission, so hospital stay was reduced as well. Active surveillance and hormone therapy was considered for prostate cancer for therefore surgery and radiation therapy, partial nephrectomy for early stage renal tumor can be considered post-developable, or urology procedures for benign diseases was encouraged to be developed, such as TURP, elective reconstructive surgery, and so on. That's all. Thanks.
Thank you so much. As far as I understood, you stopped the elective surgery for benign disease. Oncology cases were treated further, and also for stone cases, you performed only super mini PNL, having the patients just one night maybe in the department, and also in the majority of cases, you begin to treat them with shock radiotherapy, depending on the size of the stone. Is that right?
Less than 2 centimeters, maybe I use shock radiotherapy. Maybe more than 2 centimeters, large stone size stones, with sometimes for PCN, super mini PCN.
Super mini PCN. Professor Zeng, did your routine practice for the patient evaluation change? For example, did you perform specific tests and chest X-ray for all stone patients prior to shock radiotherapy or mini PNM? Did you understand? I mean, in the evaluation of the patients, did you change your policy? Did you perform chest CT and specific tests for all patients?
Actually, I must change the policy, because for this patient is going to the hospital, I must do chest CT scan and swab DNA test, or test are negative, then you can go into the hospital.
Excellent.
Must do it.
In all cases, you perform that.
Exclude COVID-19.
Okay. CT scan and test needed to be negative prior to surgery. So, Dr. Prezioso, Domenico, please, can you tell us something about how this pandemic changed your treatment policy?
Of course, a lot of things change, and I'm happy to understand, to hear that my friend Hua said that they're going back to the normality. Because as I said before, I think we will need a lot of time for normality. If we're lucky to have a vaccine, we have also to hope that will be stable and long-lasting. But it will take months. So this means that we need to discuss the treatment decision-making with the patient again, especially regarding the waiting list for the programmed operation. Because it's a matter of fact that nowadays people, and will go on for a long time, for many months, scared to come to hospital. They don't trust so much in negativity. Also, we just said from the WHO Saturday that we will never have, with this data, that we call immunity patency, license. That could be the only thing to go back easy. Because there are people that, also in Italy, after 2 negative swab, they became again positive. Also the latency of the immunity. And the biggest problem are the asymptomatic. Well, right now, we had a big problem for reactives, for the swab. And I would say that until two weeks ago came out, we could have only serology, and if positive, we could ask a swab. Of course, for any people that could be admitted to the hospital, since a couple of weeks, it's mandatory chest CT scan.
Chest 6. All
Yeah.
right.
Because not always the anamnestic, it's safe enough. Well, of course, I think will be even bigger the discussion on the SWL, because in this period could be an ideal treatment for the distance respect, for no invasivity, because we have no need of anesthesia. But I think urologist has to manage better the SWL, and if what we are going to do, because we know that urologists have been not qualified from a not surgical treatment, and this led to give to the young resident, or in some place technician, the use of the machine. And of course, the results were not so nice or good, like we had with urology. But we have to go back. It's not a rediscovering for now, for us in my institution, because we have an active stone center in which there is a very hard-working lipotreater. And now everything is blocked, of course. Maybe after the 4th of May, when there will be a light breaking of the lockdown, could be possible, previous, all the triage, to start with ESWL. Because we have not forget that also the oncological waiting list are becoming very large. And, we, of course, will have to choose something only pathologists that can, that are life-threatening,
All right. Thank you so much, Domenico. And then coming to Ramon, Professor Cancino, tell us something about in your department. What has changed? What did you do for the stone-bearing cases?
Well, in our case, the selection of the patients was easy because we could select any kind of patient, only emergency situations. Talking about the stone, obviously,
Yes.
we could put a W or a nephrostomy tube in case of necessity. In other cases, no stone. For example, we have triturose hematuria or furnious gangrene or something like that. But in a stone situation, we could only put W or nephrostomy tube. That's all. And thanks to the telemedicine and for calling patients and take contact with them, we can share select patients that need to be operated by oncology situation. And we have had a big collaboration between public and private healthcare in order to be able to send those oncology patients to certain hospitals that are considered no COVID hospital and especially dedicated to make that surgery, that oncology surgery. So that has been a very big help to treat this patient in this specific area. But of course, in different regions, we have had different situations. And like in Madrid, has been very punished by the COVID. In other regions, in other areas, maybe urologists have been able to maintain or to keep at least one surgery per day or one surgery per week, especially for those patients, for oncology patients or especially complicated stone.
I see.
For example, our change, preoperatory change, has been necessary to do a PCR and checks X-ray and sometimes a CT scan in order to know how is this patient, is COVID or no COVID. But that's all. That's all. We cannot do anything else because we have no space, no place to do external lithotripsy or nothing else.
I see. Thank you, Ramon. And then if I summarize the conditions in Turkey, in Istanbul, just like my friends, we postponed all the elective cases. We dealt only with the emergency cases regarding the stone, suffering from stone patients, I mean. And in some of them, we placed HJ stent. In some of them, we needed to insert a percutaneous stent into the kidney. But in the majority of the cases, we tended to treat them with shock wave lithotripsy, I may say. If the stone size was less than 15 millimeter, particularly, we began to treat them in order to perform an emergency shock wave lithotripsy. This is also a reality, can be performed anytime. And also regarding the infection control, you need no anesthesia, only the technician, yourself, and the patient. Social distancing could be all right for during shock wave lithotripsy, and for stones obstructing a ureter was the preferred choice for us to treat the cases with shock wave lithotripsy, and in the majority of them we had success. And chest X-ray and PCR testing was a must for all cases prior to all procedures. So coming to the last question, Samir, can I have the last question? Now we are coming to an end. We will see the sunny days, and it will end, and the measures will come down. But we will have a lot of cases on our waiting lists to treat them, particularly stone cases, stones in the kidney, in the ureter, and we had postponed them for pandemic area to come down. And what will be our approach, our measures to treat all these cases accumulated in our waiting lists, particularly for stones? Professor Zeng.
Actually, in my department, elective surgery waiting list is always quite long. Too many patients waiting. But we allow still use the temporarily short clinic to distinguish the infectors and with the other patients. Actually, it adds up a lot of work for my staff, for my colleagues. But I believe it is worse as COVID-19 still exists. Currently, we continue use shock lithotripsy machine and the PCNL with this special anesthesia, palo-vertebral anesthesia, more than before. So far, it all works very well. Today, altogether, in our team finished 25 different procedures one day. 25. Maybe tomorrow, almost 30 procedures. So average about 25 procedures in our department. Now it's come to the normal conditions. Thanks.
Excellent. You are lucky. You are really so lucky. 25 cases to be operated on a day, and you have a lot of opportunities. But when it comes to Italy, Professor Prezioso, my dear friend, you told me that you are locked, no operation, nothing has had to be done for the cases, but you will have a lot of cases, stone patients. So what will you do after pandemic? They will all come in front of you and waiting for the treatment. Tell us something.
Well, we have to consider that I work in a university institution, and we have a resident. We have residents, and we should start as soon as possible with the routine or the elective surgery. But I'm pessimist anyway. For the reason I told you before. Because maybe in China it's possible to say, okay, everything is ever. You can start again with the normal. In my country, like I think all over Europe, and you saw it from the different approach to this terrible problem, will be not easy to send that we call the infection index, the R0, close to, as close as possible as to the 0.5. That could mean that you have a reduction of the risk of infection. So we have to be concrete. I mean, of course, as well as the new cases will decrease and the most of people will be cured, will be with a lot of attention, if that will lower the time of any operation. Keep this in mind, and will along more waiting list. We have to go back to the normal, but it will be not normal without a safe vaccine. That's the problem. So I think it's the moment to discuss with the patient of the real possibilities of ESWL. Link it to the volume. I agree with you guys. Less than 1.5, every patient should be treated. Why don't try? But I think that the people will have a great compliance for that. Because when you, with the new kind of informed consent we have in Italy, when you inform the patient with the percentage of and numbers regarding effectiveness and complication, needing or not something invasive, the most of patients will say how they already do. Why don't we try first the not invasive? I think there will be, compared to the last 10 years in which it has been a little abandoned, the ESWL, there will be an increased number of cases.
Thank you so much, Domenico. As far as I understood, you mean that we will re-understand the value of less or invasive procedures or non-invasive procedures, just like mini PNL or shock wave lithotripsy to treat all these cases. So coming to Professor Canzino, come on.
Well,
how the things will go further in your department? I know you are very well active in stone management. You have a lot of cases in daily routine, but waiting list will be really a problem, headache for you.
Yes, it is. Yes, it is. We are not able to do 25 surgeries in a day.
But exactly.
But we are active. We're active. Well, we have to think what to do in the day after, because we are going to have a era post-COVID, and we are going to have a waiting list that maybe is not very big or bigger than from the beginning, but it's gonna be with more time than usual. That means that those patients could be more risky and more complicated. The stone have grade, maybe some obstruction, maybe more risk of infections or stent incrusted or calcified. So probably we have to, first of all, check the history records in order to see if we have everything okay, anesthesiology or preoperatory, urocultive, any kind of image, CT, ultrasound, or whatever, and try to think if we need to actually to repeat some of them, some urocultive, some image, For example, we have to keep in mind that the radiologists are very completely overloaded. So maybe we can do in the office an ultrasound, and we have to think and to keep in mind everything. And with that information, we have to phone the patients, to call them, to speak with them, in order to try to separate two different groups of patients. First of all, we have to make a surgery in the first step, those patients, for example, with upper urinary tract tumors that are going to need an endourological treatment. Those people who had a WO nephrostomy tube, those people that have ureteral stone. Ureteral stone is a trouble that has started and need to be finished. So we have to help to close that circle and to try to avoid a complication, for example, an obstruction during the travel. Another important patients are stagger or big kidney stone, and of course, solitary kidney or bilateral stone, and those with impaired renal function. Those groups are the people that are going to need to be operated in the first step. Exactly. And in the second step, we are going to have those patients with low symptomatic kidney stone, no stented, low risk or infection or obstruction, and another people that are going to be the post-COVID patient. That people has suffered from COVID, and maybe the COVID has made a complication from respiratory point of view. And they probably are going to need a reevaluation, because sometimes we have to keep in mind that maybe those people are not going to be able to have a general anesthesia and intubation. So maybe we have to change our mind, change our indication. Sometimes, for example, sandwich-like therapy with stone, with shockwave lithotripsy and flexible ureteroscopy or something like that. But we have to keep more or less this possibility in order to treat the waiting list as better as possible.
Thank you so much, Professor Cancino. Thank you for this algorithm. Particularly, we will need all these algorithms and maybe specialized guidelines for the urologists for pandemic area. We were affected with this pandemic in an unestimated and underestimated way, and we were not ready. Yeah. We didn't know what to do, how to do, and now we have experience. Depending on such algorithms and guidelines, we will go further. If I summarize the comments coming from all panelists, the waiting list will be really full, and we need to manage them in a time-based manner, beginning with the urgent ones, beginning with cases suffering from oncology cases, and also cases requiring surgeries, less invasive, non-invasive surgeries, not time-consuming ones. For example, ureteroscopy for lower ureteric stones, mini PNL, suprapini PNL, and also shockwave lithotripsy again will be in our hands to treat all these cases, because you can treat 6, 7, maybe 10 patients with shockwave lithotripsy in a day. On the other hand, it will take time for you only to treat 2 or 3 cases for PNL. For that reason, we should be ready with appropriate algorithms and guidelines coming from the international societies or from the country also, to treat them in an appropriate and on time-based manner. So before finishing, Samir, as ULIS, we had our ECOR working group. It performed a survey monkey-based study in Europe, and we asked some questions to 6 experts, stone experts. What did you do? Which experience do you have during the pandemic time? And as you see here, the findings, it showed us that the workload involving COVID-19 patients was more than 80% in involved hospitals. 50% stated that COVID patients have been hospitalized in urology departments. 40% of the urology experts were obliged to triage all these cases and to deal with them. And 50% of the centers, the hospital administration opened new wards for COVID positive cases. Going further, Samir, 50% of the respondents experienced a change, a considerable change in their practice. The outpatient clinic workload reduced. Here you see in the majority of the cases between 75 to 90% in a third of the departments. Around 56% of experts changed their elective surgical treatment and began to postpone them. Among these experts, 73% began to use telemedicine during pandemic time and also hospital stay. They tried to keep the patient as short as possible in the department by performing less or non-invasive procedures. And last slide, please. Do we have another slide? Samir? Yes. Another area for emergency cases in 56% of cases. Here you see in 26% of experts accepted emergency stone cases in another area in the hospital. 2% of the respondents referred emergency urology as cases in other centers, and around 90% of the experts tended to change their treatment strategy by planning their elective surgery after drainage of the obstructive system. And there should be another slide regarding the specific stone type. We ask, if you have a case with a stone sizing less than 2 centimeters, what will you do during pandemic area? They reported that around 32% of the respondents will have conservative approach. JJ stent placement in 26%, and here you see nephrostomy placement. RIRS came down to 2% during pandemic area, and around 6.57% of the responders they will prefer shockwave lithotripsy. So in summary, our practice has changed to a certain extent. We got experience over time, and also in that trial, we learned that after 3 weeks, the urologists get chance to have some experience to change their practice. And we should be ready for the post-pandemic era with a long waiting list, but we need some algorithms, some clinical guidelines, and anytime in the future, we can also face with these problems again, and we may have all these difficulties in our departments also. So that was the summary of the panel, and if we have any questions from the, let's say, participants, we will be ready to reply them. Samir.
Then now this is my job coming back again.
Please, Christian,
I'm now the voice of the audience. So thanks a lot, dear panelists, for that interesting discussion. There have been really some very, very interesting insights. And also the audience has now, in the meantime, pushed several interesting questions. And there is, for example, one question more related on the patient's perspective. Kemal and the other panelists, what would you recommend to your stone patients during the COVID-19 situation? Because usually you are getting approached by stone patients, by customers from your side. So what would you recommend those patients in that situations actually?
So just 2 sentences from me. I will tell them that if he or she is an urgent patient case, I will go further and do something in terms of drainage or some conservative measures. And if I see that the stone with its properties is suitable for shockwave lithotripsy, I will go further shockwave to treat them. Otherwise, if they are not urgent cases, I will talk to them and I will let them know that let's wait till the end of pandemic in order to limit the infectious problems during surgery, during anesthesia, and then we will treat them in an appropriate manner. So, the other panelists. Domenico.
I completely agree with you, Kemal. That's the best way to proceed.
Yes, I think that's totally right. I think that people must know exactly what to do, and if they have any kind of doubt, please contact us. If it's necessary, come here. We are going to see if you need really something from emerging point of view or not. but try to do exactly that. Yes.
Dr. Professor Singh?
Yeah.
Go ahead, please.
For stone disease, less than 2 centimeters, I think is low symptoms. Maybe you can watch. You can come to the hospital, because you come to the hospital, maybe take a risk of COVID-19, and then you have sometimes colic and infection, fever, and acute renal failure, maybe low urine. Maybe you must come to hospital for emerging operation. Must you do digestion and leprous tube message, okay, enough. I think so.
Thank you so much. Christian, any other question?
Thanks a lot. Yeah, several questions that I even fear that we can't answer all of them. But one question that is also rising up pretty often from the audience is about COVID tests before surgery after the pandemic. So when the normality will come back, will you perform upfront doing the regular surgery, urology surgery? Will you perform tests to the patients?
Ramon?
Well, we have a lot of doubt about the real value of the result of the PCR or the other test that we have in the market, actually. But it's important to do something. We have to know something, of course, and the best test should be the PCR. But the most important point is to treat to any patient like that patient were COVID, because that is going to help to protect yourself and to avoid any potential transmission of the COVID. And another important point is to give to any patient that is going to suffer a surgery an informed consent in order to notify the possibility to transmit COVID during the surgery or in the hospitalization, because the patient must know that we are in a pandemic situation and we, unfortunately, we are not able to control 100%. And it's important to give that informed consent to the patient.
Excellent, Ramon. That was very important point that I forgot to tell. It should be changed because it has some medical legal aspects and responsibilities. Professor Zeng?
Yes.
Maybe you may tell something. Now we are treating the cases in a normal
yes, of course.
manner. Do you continue to perform tests?
Yeah. Yes, of course. You must do COVID test before you surgery after pandemic. Because actually in Guangzhou, in my city, is low cases of COVID-19. But some people come to my hospital for operation and must do COVID-19 test. This is must. You must protect. You must protect your colleagues, laws, staff. This is really important. Thank you.
Thank you so much. Christian, do we have time for another question? Or?
Yes, I think so. So if we can overdo 5 minutes, then we have some more time. Yes. So because there's one. Yes, there is one other question which is also raised several times. It's about the importance of ESWL after the COVID-19 situation, because you have discussed already the large number of patients in the waiting list that might appear right now. And I think there we are pretty clear and consistent that ESWL is a solution also, will be an important solution. Can this also be done in office? And this is also the question now from the audience. It comes to ultrasound and to ESWL. Can this be a real big solution for the future to keep ESWL and more ultrasound in office instead of the big hospitals?
So, let's begin with Domenico. I will tell something, but...
Well, Kemal, this is another example that people's care go to the hospital, and this fear will last long time. So, of course, there is nothing better than the SWL that does require any kind of staying in hospital. It's an office treatment. I mean, in our institution, and can give enough guarantee for the safety. But just to tell also something on the previous question. Of course, I think for a long time we'll go on with the oropharyngeal swab that looks the most reliable and useful test, because we have not to forget that we don't know so much on the immunity. We don't believe there is a flock immunity, as somebody suggested. But how long it lasts, we don't know. And that's a big problem. And we have not to forget, because we could let some focus, some cluster restart in the hospital. It is the worst way, it's the best way to enlarge the number of patients.
Exactly. Professor Gover, what will be your comment for office shock wave lithotripsy with sonographic localization and tracking maybe?
Actually, everybody know, but flexible uroscope number is increased, and now shock wave number is decreased. Actually, I think this is the best opportunity to let every urologist know shock wave is best option for treating small size renal stones. This is very, very important opportunity to remind every urologist don't forget this technique. This technique is very good, as I saw.
I totally agree with you. That's the realization of the value of shock wave lithotripsy, maybe with this opportunity. Ramon?
Yeah.
Well,
comments?
we are going to leave a very difficult. Patients, I don't know. I think we're going to need help from everywhere, and of course from external lithotripsy. But I think could be better if we keep on our current indication from our guidelines.
Thank you so much, Ramon. If I tell something about this issue, it is logical. We can do it, but we need some compact systems to use them in our office, just like sonography had maybe, to touch it to the dedicated area. And if you have enough sonography experience to localize the stone, why not? You may treat, again, as Ramon told us, with good indications for stone sizing less than 1.5 centimeter, maybe less than 1 centimeter, even European guidelines, they tell that we may use it, but we need some new systems, compact systems, to have them in our hands. Christian?
Thanks a lot for your answers. I think that we are now coming to an end of our webinar. If we have a look at our time, then we are already a bit over our time. So are there any further comments from our panelists? Otherwise, I would slowly ending our webinar. Please, let's share your last comments and then...
Christian, first of all, thank you so much for inviting us, for all these valuable experts. I know them very well. They are brothers in stone. They are working a lot in this area. And thanks for bringing us together for this important issue. Thanks for you, for the technical team, and for the responsible, valuable company. Thanks a lot. And my panelists, any comment?
Thank you, Kemal and Dornier, for the kind invitation. It was very, very interesting. I think we should underline, as Kemal did, that we need guidelines, but maybe we have to modify at the light of these problematics that we never had, and that will change, is changing, and will change any kind of approach. I'm sure it.
Thank you. Ramon?
Well, I was only want to wish you the best in health for you, for your family, for your patients. I hope in a short time we are going to recover the normality. And thank you very much for this kind invitation. Thank you very much.
Professor Zeng.
Thank you, Professor Clement and the Donia company. It is very happy to see you all. I hope we can meet in person soon in China again. Wish you all health, stay healthy, my dear friends. Thank you again.
Thanks again for Dornier. And as far as I know, Christian, this is the first webinar focusing on stone management issues during pandemic. Thanks a lot.
Exactly. So thanks a lot to you in the panel. It was really interesting, and exactly, Kemal, you're completely right. As you all can see already here on our last slide, people outside, stay tuned. We will have some more webinars coming up. You can register already. You can have a look at that webpage that you can see there. Also, through our regular webpage, you can be linked to our COVID-19 webinar. So there will be more coming up. Very interesting, hopefully in the same way interesting than we have it today. So thanks again, dear panelists. I think you have already done a great summary now in the end. I wanted just to add some more things. What I figured out also during our discussion right now is we see the difference also between Europe on one side and China and Asia on the other side. So in China with Professor Zeng, you are behind the peak. So you have dealt already with the worst situation already. And also through his explanations, I think we can learn a lot, like keep the patients and your staff protected. Keep on the regulations that are coming from the government, like protection. The lockdown thing is really helpful in that case. And if we are all working together, I think we can also deal with that situation in Europe, in the US, and also in the rest of the world. Okay, so this was my takeaway message. I thank you all. Samir, do you have anything more to share?
I would like to thank our esteemed panelists. Thanks for the fruitful discussion and sharing your thoughts. We look forward for more webinars for COVID-19. Thank you very much. Thank you very much.
Thank you.
Thank you. Bye.
Bye-bye.
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 Thanks a lot.
Bye-bye. Best to you guys. Bye.
Thank you. Thank you.
Bye-bye, my brother. Thank you very much. Good to see you.
那个是跟死，这跟死。
잠시만요.